In this video, we're going to discuss the diseases of the aorta. It sort of crosses CT surgery with vascular. It's a short one, so there's only two diseases you really need to worry about. The first one is abdominal aortic aneurysm, the AAA. An abdominal aortic aneurysm is a product of atherosclerosis. So all those things that cause atherosclerotic disease are going to lead to abdominal aortic aneurysm. The thing that matters the most is gender and smoking. So the patient you're going to get is going to be the old guy who's greater than 65, who has at least smoked in his lifetime, if not currently smoking. And if you do this right, what you're going to get is actually an asymptomatic pulsatile mass. And usually in life, these are found because they get imaging of the belly for something else, and it just happens to show one. And if you're doing it well, you make the diagnosis with an ultrasound. And this is how you screen people. Men over the age of 65 who have ever smoked should get an ultrasound screen one time. You can make the diagnosis with a CT scan. It'll be the wrong answer on the test. What happens is usually the person gets a CT scan for abdominal pain, and we happen to identify an aneurysm consequently. But the right answer for the test is ultrasound. You might think that an arteriogram, it being a big blood vessel, would be the way to diagnose it definitively. That's actually quite wrong, and here's why. This is your heart. The aorta comes out. Most of these are going to be infrarenal, that is below the level of the renal arteries. This is the normal lumen leading to the femoral arteries. The aneurysm is going to bulge out from the normal lumen. But because it's atherosclerosis, you might have a mural thrombus. That is, the space here might be filled in by clot. And if you do an arteriogram, you see a normal lumen. If all you see is the inside of the blood vessel, you might miss the aneurysm. So you need a test that looks outside the blood vessel, either the ultrasound or the CT scan, the ultrasound being the right answer. And then it all comes down to size. If you are greater than 3.5, you have an aneurysm, and you should be screened every year. If it is greater than 4.5 centimeters, you have a AAA, but now it's high risk, you get rescreened every 6 months. If the aneurysm is greater than 5 centimeters or is growing at a rate greater than 0.5 centimeters per 6 months, you go to surgery. Otherwise, you watch and wait and rescreen. 3.5 for the diagnosis, screen every year. 4.5 pretty big, screen every 6 months. If it gets really big or it's growing fast, cut it out. 5.5, 0.5, those are the numbers you need to know. They're all 5s, 5.5 and 0.5. Those are the numbers you need to know to go to surgery. And we know definitively that endovascular repair in EVAR is equal to open. You'll get different opinions from different individuals, but the data shows one is equal to the other. Now, the way you might see this present on a test is with a person who's old and has smoked, but has a tender pulsatile mass and back pain. That back pain is referred pain from the aorta, and what's happening is that it is about to burst. So you'll do a CT scan or an ultrasound and then take them immediately to the operating room. That's about to pop. The other diagnosis you have to know a little bit about is a dissection. Dissection, aneurysm, hematoma, ulceration, if it's of the thoracic aorta and there's a hole in the wall, it's the same thing. Dissections are caused by hypertension. And so the person who you're going to see who has a dissection is going to be a career hypertensive. Very high blood pressures often. And right now, unless they're going into shock, they will also have a high blood pressure. But dissections classically present with three things. The first is a tearing chest pain that radiates to the back. The second is going to be asymmetric blood pressures arm to arm. And the third is a widened mediastinum. Now this is frustrating because there's no strict definition of what a widened mediastinum is. It just looks a little wide on the chest x-ray. But because asymmetric blood pressures is so classic for dissection, anytime someone has chest pain, you should just do blood pressures on both sides. That's free, and you're going to be in the room for more than the minute and a half it takes to do both. And if you identify asymmetric blood pressures, really consider the dissection. When it comes to dissection, there's actually not just a dissection. There's two you need to consider. This is the heart, aorta as it comes out, the great vessels, and then down towards the kidneys. A dissection that occurs in the ascending portion, that is prior to the great vessels, is considered type A. The section that occurs after the great vessels is considered descending or type B. They're going to be managed very differently. Now this is how you get to dissection. If they throw in these other elements, they really want you to drill down to the 270. But people who get dissections are not just career hypertensives, but people who have Marfan syndrome. So look for the Marfanoid physiology, someone who's really tall and lanky with flexible joints, or syphilitic aortitis. If the person is from a low socioeconomic bracket and is having lots of sex and has a history of STDs, you can check an RPR. But what I want you to feel is it doesn't matter what caused the dissection. If you catch a dissection, you can save someone's life. And the way you do that is if you see someone who has this presentation, the best diagnostic test, the one you should pick, is a CT angiogram. There are other tests you might think to get. And just like abdominal aortic aneurysm, the angiogram or arteriogram is absolutely the wrong answer. If you shoot dye directly into the artery, you might accidentally pop the dissection and they die. The CT angiogram is the test of choice because what you're doing is, if you take a cross-section through here, what you're doing is looking for the false lumen. Where you have hematoma here and regular blood here. You see the false lumen, you have your diagnosis. What it's supposed to look like is just that. Right? No green portion whatsoever. So if you get the false lumen on CT angiogram, the diagnosis is done, but you may not be able to do an angiogram if they have renal failure. And then it's whatever you have access to. TEE, transesophageal echocardiogram, is essentially equal to MRI in the way of making the diagnosis. Neither requires anything to be injected, but the TEE requires a cardiologist who can do it. The MRI doesn't. You basically pick the one that's most readily available if you can't do the angiogram. And for the treatment, if it is ascending, that is type A, you need to operate. No way around that. And because it can go forward and cut off the great vessels, they could die. And because it can go back into the aorta and cause aortic valve regurgitation, which could also kill them, you need to evaluate them for the need to replace the aortic valve. If it is descending, then you treat medically. And you do that by getting their blood pressure and their heart rate down, IV beta blockers. Now, both of these are vascular disease, so both of these are going to be facilitated by blood pressure control, smoking cessation, diabetic control, and dyslipidemia control. So chronic management is going to treat them just like a vasculopath, someone who's got coronary artery disease or peripheral vascular disease. But what you need to identify for the test is AAA, asymptomatic pulsatile mass, get the ultrasound, operate if it gets big or is growing quickly. Dissection has got the tearing chest pain radiates to the back. Get the angiogram to make the diagnosis, and then if it's ascending, operate. If it's descending, IV beta blockade. That's diseases of the aorta. Become a better doctor. Subscribe now to get access to our premium content.